Pulmonary embolism is something not new, and I'm sure everyone in the audience have seen cases and are well up to speed with management. Nevertheless, there are controversies with various aspects of diagnosis, both diagnosis and treatment. This will be a clinical talk, which is aimed at the clinician who stands at the bedside or receives a call regarding a patient with PE. We all know that it frequently occurs, from suspected PE to diagnosed PE to the patient with pulmonary embolism who crashes and goes to the intensive care. It is a common clinical problem. It is listed as the third most common cause of death by cardiovascular disease, not all cause, and follows myocardial infarction and cerebrovascular accidents. There are many dilemmas there. First is the diagnostic dilemma, as when and how to image. Then there are therapeutic dilemmas. Once the diagnosis is made, most people are treated. How long do we treat, and how do we treat? Now, this talk will focus on, first, the question of risk stratification post-diagnosis. We are not looking at the nature of anticoagulant treatment and the duration, which is well established, and also focus on the role of thrombolytic therapy, when and whom to give it to. To set the scene, we really have to walk down history's lane to first understand how and when the disorder was first described in history. And the current problems more relate to the kind of tests we use rather than the disease entity in itself. Well described in 600 to 1000 BC in Ayurvedic texts, there is venous thromboembolism with the DVT entity. And then it appears in the 18th century text, which once autopsies were being done with large blood clots in pulmonary vessels as a distinct entity. Later, French pathologists tied in venous inflammation and thrombosis in the 1800s, followed by Virchow, who could be called the father of pulmonary embolism because he actually labeled the term and described the phenomenon as we know it today in 1846. A brilliant German pathologist actually came up with the concept of embolism. And it's not just a thrombosis, it's actually the clot fragments and comes from elsewhere. He was interesting because fiercely opinionated man, and he actually delayed the germ theory by Lister and Pasteur because he opposed it tooth and nail. He's also well known for the Virchow's triad, in which thrombophlebitis and inflammation in clots were one component of it. Following that, in the late 19th century and 1800s, there was recognition that venous thromboembolism is always a severe disease and fatal. Now, from then on, to our topic today, which patients should receive thrombolysis and which patients are suitable for early discharge? In a sense, they're quite contradictory. At one point, we're saying early discharge, and in the other, we're saying thrombolyze and potentially give a treatment which can be life-threatening, and we're talking of risk versus benefit. So it is two ends of the spectrum. Let's look at this closely. In 1960s, the diagnosis was, till 1960, the diagnosis was largely empirical and on clinical grounds. And that's when testing emerged, largely evolving from the 1800s, the discovery of the chest radiograph, followed by the ECG and then echocardiography. They knew there was a phenomenon, but it was mainly a clinical diagnosis with no clear structural or functional impact due to PE. Largely the diagnosis was made on clinical grounds with supportive evidence with no clear-cut anatomic or physiological effects of the same. The ECG, all books have it as S1, Q3, and T3. Interesting that the publications were in 1935 and then 43, and really seen only when there's clot obstruction of more than 50% of the main pulmonary artery. And that's why we hardly see this ECG phenomenon, because it was described in patients with almost complete occlusion and death. Blood gases, again, non-specific, and the chest radiograph showing the Westermarck sign. Now, angiography came in 1963 with William and co-workers, and following that with Dallin and co-workers, showing us anatomical abnormalities within the pulmonary vasculature, leading to a more clear-cut and definitive diagnosis of pulmonary embolism. Now, there are major and minor features on angiogram. We're not talking about CT angiograms, we're talking about cardiac catheterization and angiograms. The major morphological findings were intraluminal filling defects, cutoffs, and prunings, and was considered the gold standard till the late 1970s. Now, there were the minor abnormalities, which were really oligemia, low flow, and a prolonged arterial phase. So a good test, but incredibly hard to do because it needs a fair bit of expertise and equipment, and the logistics of getting a cardiac cath for a suspected PE was difficult in most clinical settings. Now, perfusion scans emerged in 1964 with Wagner and co-workers first describing the abnormalities, and a few years later, and 5 years later, they actually did the ventilation scan and was an excellent tool showing defects and facilitating easier and more specific diagnosis of pulmonary embolism. This changed with CT scans and the CT pulmonary angiogram coming in, the first publication of which came in with Sinner in 1978. So the CT scan could be timed, the contrast could be timed, and we had the technology to detect filling defects through the pulmonary vasculature, a major advance. Now, the impact it has on diagnosis is quite profound. Now, you see here, and that was till 1997, 1998. This is the mortality, primary diagnosis of PE, secondary diagnosis of PE, any diagnosis being primary or secondary. This is from the United States Medicaid and their national database. Post-98, this is where we're going. You can see the primary diagnosis of PE soars. Any diagnosis incidence climbs as well. So we're talking about a non-infective or not a pandemic setting, but a disease which is effectively increases in incidence largely because of a better diagnostic test. But what is also notable is the mortality remains flat. So the impact of overdiagnosis, or more accurate diagnosis, for lack of a better term. This has been replicated in University of Western Australia, where they've done a similar study and shown exactly the same phenomenon. So, in effect, before 1997, what we were seeing was, and before the CTPA became standard, we were really seeing more major pulmonary emboli and with more significant hemodynamic effects. Post-1998, once the CTPA became standard, and shortly after that, this data in the US, in Australia, incidence soars and any diagnosis also soars. What was responsible for this? This is the smaller PEs, really, which came about. And hence, brings us to two ends of the spectrum, where pulmonary emboli were diagnosed better, but also we were diagnosing excessive and possibly smaller PEs. Now, with that, the advent and further development of the CT scanners and the slices in the CT scanners didn't help, because we got more accurate, and we all know you do a CT scan for some other reason, and they come back to you with small subsegmental PE. It was done for an entirely other reason. Now, what do we do with it? And that's really a question which we're trying to answer in literature, and it's still a moving target. So, looking at risk in PE, certainly we don't want to miss this category. We all know that it's cardiac arrest or hypertension, you're moving between the 30 and 60% risk of death. The normotensipation, and not all normotensipation, you have a subset which has less than 2% mortality risk. So the challenge here is to identify the safe patients and discharge them. At the same time, not discharge the patient who's not unsafe and have a mortality outside the hospital. And further, is admission the foolproof way of keeping a patient safe? I think not. What we do with these patients and how we monitor them is another issue altogether. So if you look at this, the numbers are highest here, and the mortality is highest here. Now, this is a bit of a haze, but we're trying to get this group well defined. And that is quite a task. So risk stratification, we've got a few tools to play with. First, the clinical state, biomarkers, and we all know troponins are one of them, echocardiography, and we're talking about more difficult tests to get during different times of the night in routine clinical practice, radiology size and extent of the clot. So effectively, there are four tools one can use to stratify risk. Let's look at this important papers in this regard to try and address this issue. So the low-risk population, as you all know, there are numerous tools available in clinical practice. The PESI score, the PE stratification index, the simplified PE stratification index, the Geneva score, which is used for diagnosis, actually there is some evidence to suggest it can predict risk. The Spanish score, the Davies criteria, home exclusion criteria, the Hestia criteria, and there is the Bova criteria. So there are a fair few here scales to use. Now, not all of them have been validated, and it's really a statistician's delight, because if you see how these scores were put together, it's large data sets, logistic regression, multivariate analysis, and trying to identify factors. I will, for today's talk, focus on the PESI and the simplified PESI, as they have been most validated and advocated and is quite robust and is able to identify a safe population. It's not without its limitations, but that's where we have the largest group of evidence, so I'll focus on those two. So what is the PESI score? 2005, initially in the American Journal of Respiratory Review and Critical Care Medicine. This was by Orjewski, 185 hospitals in Pennsylvania. They looked at a cohort of 15,000, and these were the factors they identified, and they weighted them. This was externally validated in a French cohort, and this is how they categorized them. Class 1, and the scores going up to 125. A major determinant here is age. So the data looks good, but do we actually believe that clinicians will do an accurate calculation at this end? I think not. The more complicated you make the score, the less it's going to be used. So 4 years later, they looked at, so it has an impressive 30-day mortality and is able to predict it well in an area under the curve of 0.78, taking a cutoff of less than 25. So that is, less than 65. So that is the PESI score. Going to the simplified PESI score, they effectively took the same data set and weighted it this way. Total number of 6. If it's 0, it is low risk. 1 or above, it is intermediate or high risk in most papers. So if you look at this, effectively if your patient comes in above 80, he automatically falls into the high risk category. So it's not without limitation, but it's perhaps the best we've got. And in fact, this has surpassed the standard PESI score in clinical practice simply because of its utilization and its ease, and it has been validated. So if you look at the factors, hypoxemia, blood pressure, tachycardia, heart failure, malignancy, and age. So that's pretty much it. It's something which can be done easily at the bedside. Now, what is the risk of mortality at 30 days with 14 and 30-day mortality? There we are, 1.5 and 1.9 with the simplified PESI score. The low risk, again, 2.3 and 2.7. So none of these were statistically significantly different, and it seems to fall within the acceptable range. So simplified PESI is almost as good as the PESI score. Now the accuracy, the sensitivity, as is obvious, is 90%. So if it's above that, you admit. The specificity is poor, as is expected. And importantly, the negative predictive value is at 98 and 97. So we have a sensitive tool, but it's not specific. Now, overall in this cohort, 2.2 had non-fatal cardiogenic shock or cardiorespiratory arrest. So that was roughly the data from the derivation cohort. Now, it's not just identifying the low-risk population. Now, this was devised to actually target and identify low risk. We worried also about the intermediate risk and the high risk. So the big question here is identifying the normotensive risk in a normotensive patient. We all know if a patient's hypotensive and has pulmonary embolism, it is a no-brainer. We need to either monitor them in intensive care and look at treatment options, which including thrombolysis. It's well laid out, and it is standard practice. The problem area is really the normotensive patient. And so this study looked at all-cause mortality, recurrent VTE, major bleeding, and RV dysfunction and increased risk of mortality had an odds ratio of 2.5 when you had right ventricular dysfunction. So that is on echocardiography, and the CT image had an odds ratio of 1.8 of early mortality. So the echo is better, and there is an indicator that though they are normotensive, if the echocardiogram shows RV failure, there is a higher risk of an adverse event. And that's really the gray zone in this field. So discerning the low risk, the short or no hospital stay patient, where you can send them, that if you have a PESI score which is 0, and your patient is stable, and the PESI picks up the stable patient, pretty confident to send them home on oral anticoagulants. The intermediate low risk is where, and this is the difficult area, the normotensive patient with a high risk of complication, of a complication may need aggressive monitoring and treatment, and the high-risk patient. The high risk is well laid out, significantly hypoxic and hypotensive. So, in the article by Jimenez in Emergency Medicine, this is the flow chart which is recommended, which is actually quite reasonable. Run the PESI score, it's positive, look for markers of myocardial injury. And this invariably stratifies low, intermediate, low, and high risk. If it's positive, if the troponin is positive, we'll need an echocardiogram. And if the echocardiogram shows RV dysfunction, they need monitoring and possible thrombolysis. It's not standard practice. So this is controversial, but they need intensive monitoring. The low risk, though, you could get away with standard anticoagulation. And later in the talk, I will talk about the crossover from here. Now, one of the problems which plague this field is retrospective data. There are n number of publications. 80% of them are retrospective cohort subset analysis. There is very little prospective studies. In this study, they looked at, again, retrospective, they looked at mortality during the first 30 days. And the reason I'm putting this is more to educate us ourselves about what causes death after pulmonary embolism. It's a clinical radiological diagnosis. It's confirmed on radiology. But why do patients die? Is it all PE related? And this study really looked at that closely. So 6,000 patients. And bottom line is 1,291 patients were eligible for the study. And they had troponin data on 799. Now, the PE, 127 deaths were noted. PE-related deaths were 60, and non-PE-related deaths were 67. So patients with pulmonary embolism, when you look at all-cause mortality, 50% actually are related to non-PE-related causes. It's an aging and it's a sick population. This is yet to be teased out. Malignancy plays a strong driver. They have coexisting cardiopulmonary disease. And here you see the PE-related deaths are better predicted by a troponin level. Identifying this cohort is quite difficult. Now, coming to how do patients actually behave once they present to a tertiary center with a pulmonary embolism? Again, there are very few studies addressing this particular issue prospectively. A lot of large retrospective cohorts. Now, this study by Lankett et al. Is quite a landmark paper published in Circulation in 2011. So they looked at the difficult group, normotensive patients with acute pulmonary embolism. So what they did was they did the simplified PESI, and they used a highly sensitive troponin on patients as they walked through the door. Their primary endpoint was adverse 30-day outcome, all-cause mortality, or the need for inotropic support. And the secondary was recurrent VTE, major bleeding, and all-cause mortality in 6 months. Quite reasonable. Now, 31 or 5.9% read the primary endpoint. 27 died, and 8 were related to PE. Secondary outcomes, 9 patients had recurrent PE, 15 experienced, 2.9% experienced a major bleed, and 36 patients, or 8.3% of patients, were thrombolized. So that's what happened as these patients came through. Now, they looked at all-cause mortality, and they looked at the ability of the highly sensitive troponin T and the simplified PESI to predict an adverse outcome. And they were pretty close, almost identical. So they are good tools. They looked at 0, and then they looked greater than 1, and here you can see there is a death rate, so it is quite predictive. And when it's less, when both are, when you get a simplified PESI of 0 and a troponin T less than 14, it's a pretty safe combination of tests to use. And perhaps validates what the previous studies have shown, that they can be discharged quite safely. It also shows that when you have a high TNT and a simplified PESI greater than or equal to 1, your mortality adverse outcome percentage is markedly higher than either one. So this tells us, yes, validates the studies done previously, shows that both of these have their role. Now, the predictors of an adverse 30-day outcome, of which mortality is one of the major factors, is quite interesting. Troponin T sticks out there. The SPECI actually predicts quite significantly an adverse outcome. Here are the odds ratios. And none of the others actually predict an adverse outcome. Again, validating, yes, there is a role for using the simplified PESI in routine clinical practice in the normotensive patient. At 6 months, again, there were 52 deaths, rough 9.9%, 526, and there were quite a few not related to pulmonary embolism. So this has to be factored into the thinking process and in decision making. And one has to interpret the data carefully. Not all deaths post-pulmonary embolism are related to PE. Coming to the second aspect, and I'll be quick, I'm cognizant that we're running short on time. Thrombolysis, do we or don't we do this? There were a number of studies looking at thrombolysis, and if you look at the forest plots, they actually are pretty close, with some showing advantage over the others. Most of them were in double digits, and till 2012. In 2011, in a multi-center study was initiated called the PITO trial, looking at studying this aspect of thrombolysis in the normotensive patient. So stratifying PE, I should highlight at this point a couple of terms. There is the low risk, there is a submassive risk. So in the US literature, it shows a submassive. That's basically normal blood pressure with an abnormal echo. In Europe, it's called intermediate risk. One and the same thing. And then you have the massive high risk with hypotension and RV dysfunction. So the area we're discussing for thrombolysis and the controversies about using these agents are in this group. Here, it's almost standard practice because the risk outweighs the benefit. The benefit outweighs the risk. And here, this is where the jury was out. Now, these are the list of studies. And as you can see, large number of studies till finally the PITO trial, published in New England Journal in 2014, pretty much almost double the number than the previous studies which were published on the same topic. What did it show? So it looked at high risk, RV dysfunction. So we know that this is a category thrombolysis, fine. Normotensive, no RV failure, it's just anticoagulation. We're looking at the intermediate or the submassive PE. So they included normotensive patients, less than 15 days of symptoms, and with RV dysfunction, and were TROP-T positive. A single dose, 30 to 50 milligrams of tenecteplase were used. They looked at primary endpoints. Composite cause was death, hemodynamic decompensation within 7 days of randomization. Secondary, death within 7 days, and adverse events in 30 days. They looked at bleeding risks, bleeding effects as well of the thrombolytic agents. They randomized 1,005 patients, which is a heroic task, incredibly hard to do, simply because it's not all comers. It's patients with PE, stratified, echo, stable, abnormal echo, and then enter the trial. Now, those were the numbers, roughly equal. The groups were matched, mainly CTPA for obvious reasons, because there are more radiologists familiar with CTPAs. And yes, it did help hemodynamic decompensation. Far less with 10-hectare. Now, what did it do to all-cause mortality? Not much. And here's the problem. The number of bleeds was significantly higher. And hence, it fell out from being standard practice in this particular group. Again, it's not against thrombolysis and PE. It's the intermediate or submassive risk pulmonary embolism and thrombolytics. Probably the risks would outweigh the benefits and have to be done with caution. Often it's a moving target. They come in submassive, and then they drop their blood pressure, and then it's quite reasonable to do. But it's not the first thing you inject in ED when your echo is abnormal. The role of percutaneous catheter-directed interventions, very topical. Now, there are broadly 4 categories. Aspiration thrombectomy, it's fairly easy to do. Fragmentation, rotational embolectomy, and rheolic thrombectomy. Some of the fragmentation can be ultrasound guided with a pulsar inside. There are 35 uncontrolled studies with 595 patients. So it's not the best evidence. Again, major impediments: equipment, expertise, and logistics. You could have the equipment, you could have the expertise, but the sheer logistics of identifying the right patient and putting them through has an impressive complication rate. There are 2 major studies, and they are evolving as we speak, looking at massive and submassive studies. The PERFECT study, within 14 days of presentation with CT evidence of proximal PE, with 1 main or lobar artery. So with no hypotension, some needed inotropic support. They excluded patients who couldn't be given anticoagulants and those with malignancy. So this was the protocol they followed, TPA, 0.5, and it was a slow push, and mechanical thrombectomy as well. They looked at stabilization of hemodynamics and improvement in pulmonary hypertension, and mainly looked at complications, because the big worry was, yes, these drugs are effective, but they also have a high complication rate. There was clinical success, even in the massive PE, so that's a big win, and that's a group we can salvage. No major hemorrhages and minor hemorrhage. So there is something in this technology. The risk of a major hemorrhage is lower. So it is something for the future, but in a select subgroup of patients, not in everyone. You have the ultrasound-guided assisted device, which gives ultrasound pulses, and the directed thrombectomy, and they are similar. The Seattle's 2 study, again, looked at complications, a specific ultrasound-guided catheter-directed device called ECOS. They use low-power ultrasound, and there are pulses delivered at the inside the thrombus. So they recruited 150 patients, and less than 14 days of symptoms, and mainly they were proximal PE, and that is one of the prerequisites for this. Now, they looked at the outcomes, mainly angiographic, and it is a win, not surprisingly, on all outcomes related to angiography. They have the modified Miller index, the RV diameter on CT scan, and the mean pulmonary artery. All of it improved with the catheter-directed intervention. Impressively, too, these were the bleeds, and all of them recovered. There was no major intracranial hemorrhage, and they didn't lose a patient because of a complication related to thrombolytics. So in summary, it's with low risk, anticoagulation and monitoring is quite reasonable. High risk, systemic thrombolysis, bleeding risk is a consideration. If the patient deteriorates, a catheter-directed intervention is quite reasonable, if the facilities exist. It is something of the future, and there is merit in it. Intermediate risk is the big doubt, is the big gray area for the clinician. Thrombolysis is not quite standard practice. They need close monitoring, though. And if they slip into the massive category or drop their blood pressure, it's something to consider. Catheter-direct thrombolysis, particularly when there's a bleeding risk, something to consider as a first step. So, how do I diagnose and manage PE? We've talked about risk prediction tools, accurate diagnosis, which is another topic altogether. Monitoring a patient diagnosed with PE is another issue. It's not just admission. Planning treatment with anticoagulation versus thrombolysis, which we have talked about. If thrombolysis, the modality, and there is a role for thrombolytics in submassive pulmonary embolism to be done with caution. It's not standard practice, and there is a role for catheter-directed intervention, particularly to minimize bleeding risk. The Journal of American College of Cardiology come up with this nice flowchart, which I'll leave you with, looking at the stable and the unstable patient. If the patient's stable, a low risk, yes, something to consider about. Admit to medicine or even discharge in the current environment. A submassive P with a simplified PESI greater than 1 needs admission, and probably a troponin is a bare minimum. If they are stable clinically and these are negative, yes, someone probably could do with a short admission. If there's myocardial injury or strain, they would need close monitoring for a few days. If there's deterioration, a role for escalating treatment. Thank you very much.